Everybody. Last week when I came to the podium and I said, I think I'm an appropriate person to introduce our speakers today because I've had 2 hip replacements and two knee replacements. I have since found out Galen also is in that same boat. And someone may ask you a question today. We'll see how many others will stand up. So,
yeah, I know.
So I'm going to introduce our speakers today. Dr. Kenneth Milligan received his undergraduate degree from Colorado State University and his master's and medical degree from the University of Colorado School of Medicine. He attended Yale University's Orthopedic Surgery Residency program, then University of Ottawa for his adult reconstruction and hip preservation fellowship. The doctors both will come up and speak for 10 minutes, so they'll tell you a little bit more about their specialties. Dr. Brian Tscholl is an Ohio native from the Canton area. He completed medical school at The Ohio State University and went on to complete a specialized fellowship training program in foot and ankle surgery in Baltimore, Maryland at Union Memorial Hospital. So thank you to our 2 speakers. Welcome to Rotary.
Awesome. Thank you for having me. I'm just gonna introduce myself a little bit more, but yeah, I'm Kenneth Milligan. I am from Colorado, and then I have kind of done a lot of research about hip and started off doing hip replacement research, comparing new approaches and hip replacements prior to medical school, and then that got me interested in wanting to actually perform hip replacements myself. Okay, and so wanting to perform hip replacements myself, and that kind of started my whole kind of medical school journey, going out then to the East Coast and to Canada to do hip replacements. And in that kind of journey is where I then landed to hip preservation, which is kind of beyond that hip replacement, but also trying to do procedures that potentially can prevent needing a hip replacement in the beginning. So this one here. So also before I start, just kind of bringing up that same question of what I wanted to just see if everyone could stand, seeing who's had a joint replacement or even an orthopedic procedure. Yes, yes, yes. Approximately half the room. I think fortunately for orthopedics, a lot of our surgeries do have pretty successful outcomes. Definitely hip replacements have a quite successful outcome. So I'm a little privileged in that standpoint. I was just going to talk a little bit about the anatomy of the hip, just basics really, just so that we all kind of understand. The hip is a ball and socket joint. The main part that we talk about, and when we're talking about arthritis and what is arthritis, it's really just inflammation of the hip and destruction of that cartilage over time, mostly wear and tear, but obviously there's a lot of different things that can come up. I think also just for hip preservation in general, and kind of my question of how can we prevent arthritis, we have to kind of look at a lot more of the ligaments as well as muscular structure, and that's where the hip then becomes quite complicated, and there's a lot of particular ligamentous and muscular is it okay, there we go, muscles that surround the hip. So I put this up and not to go through every single muscle, but just to kind of understand there are 21 different muscles that are going in and around the hip. And so it does make a difficult sometimes diagnosis to try to figure out what are these particular muscles or ligaments that may be causing hip pain outside of just hip arthritis. Hip arthritis is kind of the main thing that probably a lot of people have known at least someone to be affected by. It's again that destruction of the cartilage. You have the femoral head, which is the ball, and then you have a socket, which also has cartilage on it. And one of the interesting facts about cartilage is that the coefficient of friction, and pardon me, I'm a math major and biomechanical engineer also, so I get excited about the biomechanics, but the coefficient of friction is actually less than ice on ice for cartilage on cartilage. So that is what allows for such a smooth range of motion in all of our articular joints. So what does hip arthritis look like? That probably a lot of people have been familiar with. It's usually growing pain is what we kind of talk about. It can sometimes manifest as buttock pain or pain with twisting motions, flexion, difficulty tying shoes. People probably know of. What does it look like on x-ray? Well, x-rays don't really show us that cartilage, but what we do see is the lack of cartilage that, or the lack of space that is created from that cartilage. And so if you look on the left, you can see that's a normal hip. If you look on the right, you can start to see the space in between that ball and socket have started to diminish. And you also see some bone spurs and some other things that kind of go along with classic hip arthritis. So when having those conversations and me having those conversations with patients, even through medical school, one of the questions comes up is, how did I get hip arthritis? That is usually met by a couple different answers, either post-traumatic, avascular necrosis, which is a blood supply issue. But by and large, most of the time we say that we don't know, and it's what we call idiopathic. However, nowadays we've been able to kind of establish that there are a couple of other biomechanical causes for hip arthritis. And so those particularly are these abnormal kind of anatomy, a cam deformity, pincer deformity, which cause hip arthritis. And so a cam is essentially a bump that kind of forms on the anterior part of that head. And as you flex up, you can see the video here. Hopefully the people on Zoom can see that. You actually begin to pinch there. And so one of the things that we've started to do is look at procedures on how we can fix this, either shaving down that bone and repairing the labrum to prevent this arthritis. The same is that there's other times where the socket may be overgrown as well, and shaving that bone down also allows us to alleviate that impingement and potentially prevent arthritis. So if you have that impingement, what can happen is you can have a labral tear. That's a common thing that you may see on a MRI. And we're able to fix these things through actually a minimally invasive procedure through hip arthroscopy. And the nice part about that is that we now have kind of got to a point where we have good long-term and even multi-center clinical trials showing good benefit. There's some other conditions as well that we've seen. Hip dysplasia is one of them, which we've developed treatments for as well. And then also a whole host of other kind of conditions, which we can do different surgical procedures to kind of prevent arthritis and essentially fix the biomechanics of the hip so that we can potentially prolong the health of your hip. If that fails, hip arthroplasty is where we kind of end up coming to. And I think the benefit of that is that, especially nowadays with the new prosthesis, we have really good results and really good long-term data extending out now even beyond 30 years. Additionally, we've also worked on developing new approaches that allow for faster recovery and potentially lower dislocation rates, where we don't necessarily cut muscles on the way to the hip. So I think there are a lot of different improvements and things that are exciting in hip. Where am I at time-wise? All right. So the last thing I'll kind of talk about, one is a common pain on the outside of your hip. People have heard of it as trochanteric bursitis, maybe hip bursitis, all of these different things. This is one thing that also is another area of mine that I'm kind of treat as well as do some research in. What can happen with this is that you can actually get some tears of the tendons on that side. And so fixing these tendons are allow you to potentially restore some of the strength and fix that limp for some people who start to develop a limp as a result of that. and also help with pain. So that's another area that we're looking at with the hip, and really kind of addressing multiple different areas, including posterior hip pain, which is a whole host of things, but really kind of teasing out sciatica and trying to understand that not everything is sciatica, but there may be something else that's there that we can help. So I think that is for me. I'll let Dr. Tscholl come up next.
All right, thank you again. My name is Brian Tscholl. I am a orthopedic surgeon at Orthopedic ONE. My subspecialty, my body part of choice, if you will, is the foot and the ankle. And so, I mean, we all have to pick a body part. Eventually, I'm just going to become a left-footed foot and ankle person. That way, I have to stop answering questions about when I can drive again. That's my ultimate goal in life. So, thank you so much for having us today. Oh, and just real quickly, Dr. Tscholl, not that guy. He's the other guy. He's gelling. He's not an orthopedic surgeon. He's just a podiatrist. But he has a successful brand. So that's that Dr. Tscholl. I am this Dr. Tscholl. All right. So one of the reasons I love foot and ankle and just medicine in general is it's just so dynamic. The things that we know or that I am doing right now are definitely not the things I was doing 15 years ago when I came out of training. The field is changing rapidly. The body of medicine, medical knowledge that we have expands so rapidly that this is one of the reasons I really enjoy medicine, and probably one of the reasons that we do subspecialization as well. It's almost impossible to keep up anymore. If you talk to an orthopedic surgeon that maybe 50 years ago, they were an orthopedic surgeon. They took care of orthopedic issues, whether it was hip or hand or a foot or shoulder. But now the body of knowledge is so great that when you get into a community like this, like Columbus, where there is such an excellent education system and an educated customer as well, or patients, that they want to see the subspecialist. And so that's why we have the subspecialization that we do. So I am the foot and ankle. That said, the foot and ankle offers a dynamic and wide range of things for me to go into. I chose to focus, of course, on lasers, robotics, and stem cells. I'm kidding. But my partner says that if you bring up those three topics to patients, they are really all ears. They want to hear all about that. And so I put up a snake oil thing. There is maybe some truth to some of these things, but maybe not. These are the buzzwords that consumers love to hear. But I chose three topics to discuss that I think are new. It's certainly not necessarily things that I worked on in training, but I find interesting in terms of what's new in foot and ankle surgery. I'm going to talk about total ankle replacement. I'm going to talk about 3D printing, and I'm going to talk about minimally invasive surgery. Everyone has heard of going straight into the total ankle replacement. Everyone has heard of hip replacements and knee replacements. We've had people who have gone the quad, all four. Shoulder replacements, not that far out of the box, and good chance that some of you may know someone who's had that. I'm guessing, and I'd be guessing that because I have a lot of patients who say this to me, they didn't know you could do an ankle replacement. That is a novel concept to them. Ankle replacements have been around for quite a while, and at first we sucked at them. We took a hip replacement, we turned it upside down, we stuck it in the bottom of the leg, and we said, how'd you do? And not surprisingly, we did horrible. But over time, and that was many years ago, 40, 50 years ago, over time, we're now on what we'd call our fourth or fifth generation of the design of ankle replacements. We've gotten much better, and the results are much more encouraging. So an ankle replacement is now something that is done with regularity. So one of the reasons I bring it up is just to bring up and educate the room that an ankle replacement exists, that it's something that can be done. They are much less common, like I said, than hip and knee replacements. The reason that they're not as fun is that it requires a period of non-weight bearing. Dr. Milligan does a hip replacement. He gets you up and walking 2 hours after surgery, and you're home within 4 hours. With an ankle replacement, I have to have you in a cast, and you're non-weight bearing. You're off the foot for a couple of weeks, and that's not so fun. That's not an easy recovery. It's the same amount of weight that goes through a knee, but it's a much smaller surface area. The load that area bears, it's much smaller. It's more difficult incision to heal. As you get further away from the core, from the heart, the blood supply isn't as good. It just takes longer to heal that area. The indications for doing an ankle replacements are arthritis, and Dr. Milligan did a good example of describing the breakdown of the joint. That's what makes up arthritis. It's arthritis in the ankle is a little bit different than the hips and the knees, though. This is almost always the result of trauma. And who gets trauma? The younger person, the person that's not doing what they should be doing, the one that's out on the ice or playing sports and then tearing things, ripping things, breaking things. And those breaks, that breakdown in the bone, the breakdown in the cartilage is eventually what comes back to bite people 20, 30 years down the road. So that typical ankle arthritis patient is younger than your typical hip or knee replacement. And that's why. The thing that's new, because I mentioned, even though they weren't so good, ankle replacements have been around a long time. The thing that's new is the idea of patient-specific instrumentation. And this is a really cool concept. It allows you to do the ankle replacement almost virtually or ahead of time based on imaging that you would get or information that you would get from the patient before surgery. You evaluate the patient, you deem them appropriate for an ankle replacement based on your exam, based on your x-rays, and then you go ahead and get a CT scan. That CT scan, that CAT scan, will give you information that you can create these 3D cutting jigs. And that's the picture on the top right corner of the black background with the white cutting jigs. Those are actually very specifically printed based on the patient's anatomy, so that you can go in and those implants fit exactly where you think they should fit. And you've already almost virtually done the surgery, because a lot of the problems with the surgery is going to be getting the implants in the right position. So you go ahead and make those cuts in the operating room, and it decreases the variation. And it will give you the more reproducible results. So basically, what I have here is the idea of getting that CT scan. You get a CT scan giving you a 3D image, and then a company will go in and virtually do the surgery for you. Oh, this is where you want to make your cuts. This is what the result is going to look like. And then they will look at the overall alignment of the patient, and you can go ahead and you can get it laser printed, or you can get a 3D print. It's not quite a laser, but it's pretty cool. And that's what gives you some good results. Next thing I want to talk about is 3D printing. 3D printing is another new concept where if you want to go ahead and make up for some kind of defect, you again get some imaging, you get some information about the patient, and you can submit that to a company who will then go ahead and create a 3D implant for you that will be appropriate for the patient's anatomy. And this could be useful in a multitude of cases, and traumas and infections, cancers, or there's a particular process called Charcot bone loss, and that is a very particular to patients who are usually diabetic, who are insensate, whose bones have almost melted away, and you don't have anything to do to make up for that. In the past, we've taken some bone, some cadaver bone, some just kind of generic stuff, try to saw it, fashion it, cut it in the operating room to make up for something that you're going to need, and that's just a little bit more crude. When you do this, it can take that CT scan, give you 3D information. You use it against a template, sometimes on the other side, to see what normal is, and that creates some type of cage. I have one in my hand here. This is what one would look like. Based on information, a company will create a particular implant for you that's metal and that has room for bone ingrowth, or you can design it for however needs that you might need. This particular patient, this case example, a patient's x-ray on the left is what they were a couple months ago. That they don't have a lot of abnormalities in their hindfoot. In the picture on the right, what I'm trying to show is that a lot of that bone has melted away. And I need to do something to make up for that. So I take this information, I send it to a company, I say, okay, what am I going to need? What am I going to do? What do I want my final product to look like? This is where they are now. This is where I want them to be. And they create this cage for me. This cage can then be used to implant into a patient You put a rod in there, you put your screws, you regain your height, and that's what lets you fill this defect. So it's a really cool new techniques that we have that weren't available 10 years ago. So I really like this. This is a new concept, not done every day, not done every month even, but something available to us that's new.
Did you see the bone eventually grows into that?
Yes, the bone will grow into that.
The bone will grow into it.
The bone. During the time of surgery, you pack it with some of the patient's own bone graft. So basically, that metal is almost the structure, and then you put some cadaver or some of the patient's own bone in there to act as the biology. The last thing we're going to talk about is minimally invasive surgery. This is why it's called go small or go home. So minimally invasive surgery is the idea of using not so much of a stretch, smaller incisions. But we have new tools now that will allow us to use smaller incisions to still do what we want to do. We can make smaller incisions and use these new instruments, these newer burrs that will allow us to cut bone. The burrs, this isn't a novel concept. We've thought of going small with our burrs before. The problem in the past is we used these burrs that were high speed, and that would just burn the bone, and we had poor results. These are newer technologies that allow lower speeds but higher torque that allow the bone to still be cut, and we can do this under X-ray. So we can do it in the operating room under X-ray, and we can kind of know where we are with these burrs, cut our bones to get our desired effect. Less postoperative pain, which is a really nice thing, especially in the new world we live in, then limiting the amount of narcotics we attempt to prescribe and things like that. Less postoperative pain is always a good thing. Improved cosmesis and potentially a quicker recovery as well. Particularly applicable in bunion surgery, where we do this through these very small incisions. It can be used in bone prominence resections and hammer toes, or in cutting the heel as well. Just a quick case example, patient on the left has a bunion, patient on the right after surgery. I'm not showing the incisions, but they are a couple of small percutaneous stab incisions that can be used to achieve the desired result. That's what I have. Yeah, that'd be great.
Go on up. Answer any questions.
Kenneth, I would love to entertain any questions you might have right now.
Yeah, I was gonna say, you know, I seem to be surrounded, but apparently I am surrounded with a lot of people that have had this surgery. And I'm wondering, as a 70-year-old woman, what am I don't have any joint pain, thank goodness. But as I'm doing my exercises and I'm doing my strength training, I believe that I'm strengthening my muscles to support my bones. How do I know I'm not wearing out my joints? And I'm screwing myself by. Where's the line?
You don't have to worry.
Yeah, so I think, you know, the American Academy of Orthopedic Surgeons do have recommendations. There has been studies that shown that it's helpful to have low impact activity. So as you move, that does help the joint fluid move around in your hip. And so it's actually, it is a protective thing. Now, you know, probably running, you know, ultra marathons is probably extends beyond that, but
yeah, but I'll also, okay, so full true confessions, I'm a runner.
Yeah.
And so everyone always asks me, you know, so one thing, it's always better to stay active, stay moving, and they'll tell you it's better to be thin than not be thin. So, you know, if running is what helps you get there, then that's very important. There's not been great studies that would show that running has a direct correlation to knee arthritis and hip arthritis. However, there's a caveat there. If you have abnormal mechanics, let's say you have an ACL tear and you are running, then the mechanics of that joint, it doesn't wear as smoothly. There's probably a hitch in your giddy up, so to say, that will cause some wear down and breakdown sooner than later. So assuming you have normal mechanics, then staying active with the impact activities is still okay.
Good advice, Scott.
A question for Dr. Milligan. Have you heard of the Birmingham hip resurfacing? And like, would you consider that a hip preservation surgery or more of a joint replacement?
No, that is a great question. I have actually did a lot of those procedures in fellowship in Canada. There are a couple things to kind of keep in mind. I think one of the reasons why it is a little bit lower is that there's only one prosthesis now in America that is approved or FDA approved. That actually wasn't the case about 15 years ago. There were actually more than one. However, there is those implants are a metal on metal articulation. And so typically when I would counsel patients when we do these, and we did these at least 2 to 3 a week, there is a 1% chance of a sensitivity to that metal on metal particles that can cause formation of what we call these pseudotumors, predisposed to infection. And so for those reasons, at least in the US, there's a lot of litigation surrounding it. So now there's only one prosthesis. In general, it is a hip replacement procedure, and it does have good, what it does is allow you to restore kind of more of your natural anatomy. But I would say that it does have a couple other risk factors that are associated. One, that metal on metal hypersensitivity. Two, another one is fractures. And so that's actually probably one of the biggest reasons why we don't use it or why it's not as commonly used. Typically at this point, it's, you know, I was doing it in Canada and it was mainly like military special forces guys who had, you know, early arthritis in their 40s. But outside of that, I think the fracture risk is quite high for general population.
Question?
Yep.
Are there other species that have the same issues humans have in terms of walking and moving? It seems like between the hips and the knees and the ankles, have we mastered being a bipedal creature? Or this is happening to us.
Yeah, I mean, I occasionally talk to my friends who have like these hybrid doodle things that dogs, and they have their hip dysplasia problems and things like that. So it's not arthritis. The idea of inflammation of a joint is not unique to the human species. What do you want to say about that? I mean, we have probably, yeah,
Have we mastered walking?
Walking.
On two.
right, no. As opposed to what we did the hundreds of millions of years ago. Probably not, but we're doing a pretty decent job.
Yeah, I mean, I think some is just also the extension, you know, life expectancy is greatly improved, as well as just physical activity levels. I think prior to this, a lot of people would accept kind of decreasing their activity levels as they got older. And I think the demand for patients is much higher to be as active as they were when they were younger. And so that's, I think, where all of these kind of procedures are really aimed at.
You're certainly right. In 1920, the 80-year-old patient wouldn't, I mean, if you just said this is it, they'd say, okay. And then now your 80-year-old patient says, what do you mean this is it? I got this cruise and I got this time in Florida and I got this and that. And I gotta go. Born to Run, one of my favorite books I've read, is a great book that talks about our evolution and really our desire to keep, the author's point is to keep running, but a really cool book that kind of addresses a little bit of that bipedal, how have we done. It's a great book.
You know, years ago, it was, people used to put off having their joints replaced, saying, well, it's only going to last 15 years. I know I put my first hip replacement off. I had it in 2011 and wish I would have had it sooner. Same with my knees. But there's always that fear that, well, the replacement joint's going to wear out. What's new today? Is that true or no? Or?
No, so at least for hip replacement, I think that's probably one of the, it's not as necessarily a new thing. I think you know, we've actually have our devices that we've been using are probably at this point close to 20-30 years old. But I would say that the plastic liner, so the bearing surface, that's the surface that moves and that's the surface that wears out, I guess. That surface has now at this point, I think, been optimized to the level where, and I had a slide I was going to put on there, but in the interest of time, I took it off. But what it did was showed you how much plastic wear would come from our prior implants and what it is now. And essentially what I tell patients is it's close to about 10,000 times less wear So in biomechanical studies and testing. And so at this point, I would say that, you know, this is actually a question that has been posed to lots of hip and knee surgeons. There really are no restrictions. We don't put restrictions even on running, I think, at this point for a hip replacement, because the wear profile is so low, and it's unlikely that you wear your hip out. There's still other risk factors for why you may have to have it, you know, taken out or something like that, infection. But pure wear and tear, I think at this point that articulation is the wear is so low that I don't think we'd ever wear it out in our lifetime.
And we are not, in the foot and ankle community, we are not as smart as our hip and knee colleagues. Like I showed you, we were trying to do what they did 50 years ago, turn their stuff upside. So we still have concerns. Right now and no, a lot of this has to do with the fact that it is a smaller joint, same amount of surface, but it's much smaller surface area. So right now we have good studies that would suggest that 90 to 95% of our implants are still in place 10 or 11 years later. So that's a good number. We're happy with that, but our data isn't as good as the hip and knee surgeons yet. So I think the bigger question is, if you have hip arthritis, if you have arthritis, how bad is it? Your first step is never joint replacement. Your first step is going to be stretching, physical therapy, anti-inflammatories, maybe a steroid injection or a Synvest. Surgery is never the first question, the first option for treatment, but surgery is an option, and I think that age shouldn't necessarily preclude one from talking about getting a replacement.
Talk about older people wanting to stay active. What do you think about younger people who are having all these procedures? They may not be having surgery, but I mean, the sports are really, it seems like, hurting their bodies. What's the research, or what are you saying in your community?
Younger people, are you talking the high schooler kids? They need rest. I'm only coming from personal experience with this. I have an 8th grade daughter who is soccer, goes straight into soccer, goes straight into more soccer. There is no downtime. It's absolutely ridiculous, and yet we're buying into it. We're doing it in our household. But we're trying to advocate for some rest, trying to advocate for some cross training. Maybe there are days where we do some more time. Maybe there's times maybe in the gym or working on some more strength training, injury prevention. I think we've come a long way, especially in females, and knowing how the ACL can be injured in sports like soccer and basketball, and trying to injury prevention with that. But yeah, in general, I'd say we are a society where we are doing way too many sports with not enough downtime. And I see I see a lot of foot and ankle overuse injuries, you know, ankle sprains that there's not letting them heal. And it's almost like patients come in with a bad ankle sprain, the kid's gonna be out for 4 weeks. And you would be amazed at how irate some people are at 4 weeks. But the regional so-and-so tournament of champions is happening for my 8-year-old. Yep. Sorry. So it does take a little bit of let's reality check. I don't know if that's the word to use, but yes, there needs to be some downtime at some point. Yes.
Thank you so much for the talk.
I know that the same question.
Thank you so much. They will be taking questions after the meeting today, so feel free to line up and ask your question. We do have a 2-minute spotlights. Actually, we have 3 of them. I'd like to have John Davis come up and